Welcome, everybody. My name is Shruti Katari. I lead industry initiatives at Blue Shield of California, and I will be your moderator today. Welcome to the event, Innovation and Collaboration to Support Community Health. Today, we'll be discussing leveraging partnerships to provide culturally relevant care in the wake of COVID-19. And our panelists include Dr. James Cruz, who is the Chief Medical Officer at Blue Shield of California Promise Health Plan, Carlina Hansen from California Healthcare Foundation, Janet Martinez from Cielo, Abner Mason from Same Sky Health, Elisa Tuluo from the Southern California Pacific Islander COVID-19 response team. Before we dive into the panel itself, we did just want to take a moment to acknowledge the Indigenous communities across all of California, including communities in the Bay Area where Blue Shield of California's headquarters are. And of course, LA and San Diego, where the organizations of our panelists, Janet and Elisa, serve Indigenous communities. So our event today really focuses on how community partnerships can help create a more equitable system of care for all Californians. And by acknowledging that California lies on unceded land, we emphasize our collective responsibility to seek out and dismantle racism and oppression in our systems of care. And really, this is to achieve a more equitable and just society. So in respect and in service of the Indigenous people whose land we occupy today. But without much further ado, I would love to call up our panelists. It is wonderful to see you all. We've intentionally brought together community leaders and innovation drivers working in California and really addressing health and social disparities to enhance access to care in culturally relevant ways. But to kick us off, maybe can each one of you introduce yourselves and tell us a little bit more about how your organizations are supporting community health workers in California?
Thank you so much, Shruti. And I want to thank Blue Shield for allowing us to be part of this conversation. Before I introduce myself, I want to at least pay my acknowledgement. Thank you for already providing the land acknowledgement, as it is part of our cultural protocol also as Native Hawaiians and Pacific Islanders. I also want to pay my respects to many of our elders who have paved the way for the work that we're able to do to serve our communities. And that includes somebody that we lost late last year, Cowan Young, who brought together the Southern California Pacific Islander COVID-19 response team at the beginning of the pandemic. My name is Alici Tulua, and I currently serve as the data workgroup lead for the Southern California response team. Serving in that role utilizes my skills as the project director of the Native Hawaiian and Pacific Islander Data Policy Lab, which is housed at UCLA's Center for Health Policy Research. Our organization was started at the beginning of the pandemic to serve the Native Hawaiian and Pacific Islander community in response to what our community was going through as one of the most vulnerable during the pandemic. We're a coalition of 20 nonprofit organizations that serves Southern California and the Central Valley. And we're proud to be able to provide culturally relevant and linguistic approaches to the Native Hawaiian, Samoan, Tongan, Marshallese, Fijian, and Chamorro community of the counties that are in Central Valley and Southern California. And we're able to do that because of our collective work. And we're proud to be able to provide that through many different programs that many of them developed during the pandemic and allowed us to be innovative, including what we were able to do through the support of Blue Shield. So I hope to be able to share some of those during today's conversation. Thank you.
My name is Abner Mason. I'm founder and CEO of Same Sky Health. Same Sky is a health technology company that uses analytics to identify disparities and barriers to care. We work with all patients and health plan members, but we have developed a deep expertise in serving underserved and diverse and low health literacy populations and others who really struggle to connect with healthcare. Our solution allows us to incorporate a lot of data, an enormous amount of data, and that allows us to understand who people are at a deeper cultural level. And we believe that that's the way to build relationships, and that understanding of who a person, a plan member, or a patient is at a deeper cultural level allows us to create a more personalized, customized engagement experience. And that in turn allows us to navigate people into healthcare at the right time in the right place so that we can close gaps in care, we can improve health outcomes, and create the health equity.
Hello, everyone. Badirs, everyone. Nedaria Janet Martinez. Bene Jojo Neda. I just basically said, hello, my name is Janet Martinez. I'm a Zapotec. Our organization is Comunidades Indígenas en Liderazgo Cielo. We're located in South Central Los Angeles. Currently, Cielo provides a diverse amount of programs. We have our financial solidarity that we just ended, which was the Undocu Indigenous Fund, where we were able to place $2.2 million in solidarity aid during the pandemic. We also have a food distribution, food pantry program. We have the Center for Indigenous Language and Power, which is our Indigenous interpretation service that we provide all throughout the United States. We provide Indigenous interpreters in various Indigenous languages from Guatemala and Mexico. We provide around 300 calls a month of interpretation. So our language access service is one of our pillars in our organization. We have community education, where we have cultural awareness trainings for institutions and for different partners that we have here in Los Angeles, but also in the United States. We also have a COVID education program that we've been doing COVID vaccination outreach. And we have cultural programming, which is language revitalization. Part of that language revitalization work that we're doing, we have a literature conference, and we also have a language revitalization classes in Maya Yucateco, in Mixteco, and Zapoteco.
I just want to say, I'm pleased and honored to be here with this impressive group of folks and this distinguished panelists. I'm James Cruz. I'm a physician and the Chief Medical Officer of Blue Shield of California Promise Health Plan. And in terms of our support of community health advocacy, in 2019, we contracted with Partners in Care Foundation to pilot a community health advocate program. Our community health advocate program was created to support whole person care needs by helping individuals of all socioeconomic status navigate and support or access the community resources and social services that they need, as well as the medical care in over 20 locations across California. We first piloted this program at our Antelope Valley clinics with 5 community health advocates that were co-located on the clinic site to serve members when they were visiting their primary care provider. And the program has been a huge success. And based upon that success, we now have 28 community health advocates working with our members in a variety of settings. They still are there co-located at our Antelope Valley clinic, working with our members when they visit their primary care provider. They work telephonically within our social services team, and they also are on site with the community at our community resource centers that we operate in partnership with LA Care. So it's a program that we're very proud of, and it's had a huge impact on being a source of information and matching members with their resource needs.
So great to be with all of you today. I'm humbled to be with such an amazing group of panelists, and thanks again to Blue Shield Industry Initiatives. My name is Carlina Hansen. I'm a Senior Program Officer at the California Healthcare Foundation. For those of you not familiar with the foundation, we are dedicated to advancing meaningful, measurable improvements in the way the healthcare delivery system provides care to the people of California, especially focused on people with low incomes and those whose needs are not well served by the status quo. A lot of our work at the foundation centers on Medi-Cal as the cornerstone of our healthcare safety net. And specifically, we've worked for the past 4 years to advance community health workers and promotores de salud, working in intersection with health systems in the state. And for the foundation, that work is really rooted in the belief that community health workers have the capacity to bring our health systems closer to community, which is what I look forward to talking to you more about today.
Thank you all so much for being here. Really, truly incredible panel. You all are tackling this in different ways and providing immense impact for our communities. Before we dive into how your organizations were able to leverage partnerships and technology to really provide that critical information and services through the pandemic and beyond, I wanted to briefly just touch upon social and health needs in our California communities and what they're facing. Janet and Elise, your organizations serve Indigenous communities in Southern California. Can you describe a little bit more about what your community's needs are and how has the pandemic really impacted your communities?
Thank you all. So at Comunidades Indígenas en Liderazgo Cielo, we focus on serving Indigenous migrant communities. That means communities that come from Guatemala, from Mexico. On staff, we have a lot of Indigenous language speakers. We have people that speak Zapotec, Quiche, Acateco, Canjobal. I think it's a really important piece of the work because we know that there is a large gap in addressing interpretation when it comes to accessing health for Indigenous migrant communities, right? And that's only, I think, one of the first hurdles. I would also say the second hurdle that we face or challenges is the lack of knowledge on Indigenous migrant communities that reside in Los Angeles and the lack of data, right? I don't think that there's any real hard data of what are the communities that reside in Los Angeles. Of course, if you have firsthand experience and every day in your work, you know who you interact with, right? We can say, hey, in South Central, we know that there's a lot of Canjobales. If you go to Mid-City, it's more Quiche. If you go into a little further up towards a little bit further up from MacArthur Park, you know that there's a lot of Zapotecs. And so I think that like one of the tools that we were able to develop at Cielo was the data mapping. Through our Undocumented Indigenous Fund, we did place $2.2 million where we conducted surveys with the families that we provided those funds to. So we were able to survey around 2,500 unique households without duplication. And of those 2,500, we see in our dot density map that we have 11,000 individuals presented in our map. So you're able to see from zip code to area in Los Angeles, who speaks what language. And I think that this is one of the biggest barriers that we face, at least when providing services to Indigenous migrant communities, a lack of knowledge that there is. And I think furthermore, one of the things that we know is that there is not a lot of opportunities to share knowledge about Indigenous communities with different service providers and institutions in Los Angeles. So I think that that's one of the biggest challenges that we faced during the pandemic and beyond.
I think what will be helpful in contextualizing the community needs that we face as Native Hawaiians and Pacific Islanders, to give a little bit of background about our community. Many of the communities that's part of our population came to this country as a result of colonization and militarization of our home islands. A testament to that is the history of the Native Hawaiian community with the United States as a nation that was illegally occupied, and as a result eventually became a state. And so there are many of these histories that are shared across our communities. And so that means that depending on the relationship that the United States has with our home islands, those relationships determine the levels of access that our communities have to resources here. That also means that many of our, because of the diversity of the groups that make up our community, there's diversity in culture, diversity in languages, which poses its own set of challenges. Another factor that contributes to the issues that we face is the history of colonization means that many of our different communities came to this country at different times. And so we have folks that have been here for many generations, and we have folks that have been here for only a couple of decades. And so the level of assimilation or adaptation to this country is very different. That poses its own set of challenges. Our communities also really spread out across California, and so there isn't really a hub for many of our populations. And so place-based initiatives and funding structures doesn't always misses our community because we're so spread out across the state. That also means that there's a lack of infrastructure and therefore capacity for being able to address many of the issues in our community. Many of our communities are also very communal, which poses its own challenges when it came to the pandemic, because we're so closely linked to each other and really thrive when we gather and contribute together as a collective. And so that means that when the pandemic hit our community, a lot of we were already facing a lot of challenges around social determinants of health. And so many of the risk factors for COVID-19 was impacted our community. Things that we already had high rates of chronic disease. Many of our communities really had disparities across a lot of the social determinants of health, which meant that we were already challenged with poor outcomes. And so when the pandemic hit, our community was very vulnerable because we had many of our families live in multi-family households. It's a little bit more crowded than the average household. A lot of our young people worked several jobs, and so we're in the jobs that were necessary during the pandemic, and were very mobile in and out of the house. And so there was high risk of exposure for our families. Many of our families live in multi-generational homes. And so that means we have elders that were very exposed to, a lot of our workers that worked several jobs and were very mobile during the pandemic. And so with already existing poor health outcomes within our population, a lot of the factors that exposed our community really put us in vulnerable positions. And so, many of the challenges that Janet raised, including the lack of data to really tell the real picture of what was happening in our communities, is a challenge. And so all of those things put together meant that we ended up being one of the populations that had highest case rates and highest death rates based on when you take population size into account. And so all of those things put together meant that there needed to be robust response to our community's needs during the pandemic. Unfortunately, because of lack of investment, a lot of our nonprofits were much smaller and were less visible to funders to be able to support. However, many of our small populations made it a point to build really strong relationships, which is one of our strengths as a community, so that we can leverage those relationships to bring in funding. It's how we were able to gather to create the response team as a collective, as a coalition, and how we've been able to leverage our different relationships to bring in the funding to respond to the community's needs.
Thank you both for sharing your experiences and really extremely important work that you're doing for the communities. Wanted to turn a little bit to community health workers and promotores. What are community health workers and promotores, and how can they help provide care in marginalized communities? Maybe Carolina, we'll start with you on this one.
I mean, first of all, there's a lot of definitions for community health workers, but I think generally people refer to them as acting as a trusted cultural bridge between communities and health and social service systems. And their work didn't start with the pandemic. If anything, the pandemic shined a light on a workforce that had already been working in communities of color and Indigenous communities for a long time. And they were really well equipped to respond in force to the issues that came up during the pandemic. Though ultimately there were some amazing partnerships with health and public health systems. What I think is really fantastic about this workforce is that they didn't wait to be asked by those systems to help. They are close enough to community that they saw firsthand what was happening and responded immediately. They started up call-in centers for justice-involved populations. They developed culturally responsive COVID outreach tools. They went into farm worker communities to facilitate COVID testing programs. The list really just goes on and on. And I think that's really reflective of why they are so important in our healthcare systems. They share a lived experience with many of the people that they work with, which means that they really have the tools in their toolbox that can be incredibly additive to our systems of care if they're engaged effectively. And there is really strong evidence around the effectiveness of community health worker models, and that combined with the visibility of their work, the reckoning of our health systems with the impacts of racism and poverty, have really stirred up some exciting policy shifts that, if well executed, will strengthen and spread the capacity of this workforce, which I know we'll have more of a chance to talk about as the panel goes on.
You know, in terms of the importance of the community health advocates and community health workers, you know, we found them to be critically important, especially during the pandemic. You know, we've seen that social needs have increased, and unfortunately, a lot of times resources have shifted or were not available. And the pandemic really exposed and amplified some long-standing systemic health and social inequities that have been experienced by, you know, marginalized racial and ethnic groups that were also at increased risk of infections, hospitalizations, and death. And one of the ways that our community health advocates were able to really help us ensure the provision of care is that they were able to administer a unique COVID-19 screening assessment tool to not only evaluate a patient's social needs at risk or impacted by COVID-19, but also to help them identify a location where they could receive other services. They were able to provide support to patients who were experiencing anxiety, stress, and fear during this pandemic, and assisted them also with how to use telehealth, which was sometimes the only way in which they could access care. They worked to help our members coordinate care and finding resources for any newly identified social needs. And as I said, kind of being a sort of a rock of emotional support for patients. So overall, you know, our guiding principles have been to really build the capacity to serve members as trusted and reputable sources of COVID-19 information, and for our community health advocates to encourage vaccination and to address health disparities that have been aggravated by the pandemic, and to really help strengthen a community infrastructure to meet that demand. So it's been a real important bridge between us as a health plan and members in the community.
We also know that digital tools are really important. And, you know, when we think about like COVID vaccination response plan, telehealth, virtual ways of reaching patients and plan members. So let's talk a little bit about how can technology be leveraged to help reach marginalized communities, especially during emergencies, to connect them to the right local resources. And Abner, why don't we start with you? SameSci has done some amazing work in this space.
I think the key thing that we recognize and that I want to sort of emphasize is that it's really important to build trust with patients and health plan members, and that technology alone is not the solution. It's using technology to drive engagement, and we believe that the best way to do that is to, in effect, kind of get away from the way so much of healthcare works today. And that is, it's too one size fits all. The way healthcare works, let's face it, it's one size fits all. Particularly when it comes to engaging that health plan member or engaging that patient, we might translate a message that was written by English speakers for English speakers. We'll translate it into other languages, but it's still the same message. And that one size fits all. What we found is it just doesn't work very well anymore, and that we've got to move away from that and to create more personalized, customized experiences. And that's where technology can come in. What we found is that if we can take advantage of the data sources that are available to us today, public data and private data and claims data, and in our case at Same Sky, we built a technology platform that allows us to ingest that data, and we built a team that comes from the communities we're trying to serve, and the combination of that team and the technology platform and the data allows us to create that more personalized experience. And what we found is when we do that, and another way to describe that is just to say this: we believe you have to treat people like who they are matters. They're not a number. They're not just a customer. They are a person with a history. They belong somewhere. They come from somewhere. They have a certain kind of experience with the healthcare system. The social determinants of health impact them in unique ways. And what we found is that if we take that into account when we engage, we can get better results. And that's what we're getting. I'll give two examples. We've done some great work with Blue Shield of California's Promise Plan. Incredible success. This was done pre-COVID, closing gaps in care around cervical cancer screenings and well child visits and diabetes screenings. Incredible results in partnership with Promise. And then recently, with another managed Medicaid plan, we've been able to close to get folks vaccinated. One plan, we were able to get a 400% increase with the folks we engaged versus the people we didn't in terms of getting vaccines in arms. All of this is to say, if you treat people like who they are matters, and we can do that today because we have the tools, you can get higher engagement, you can build trust, and that's sorely needed now.
Yeah, thanks so much, Abner. Totally agree with you. During the pandemic, the foundation did a big statewide survey, and we surveyed Californians with low incomes about their interaction with telehealth. And about 3/4 of the people, respondents of color who received care during the pandemic, got care by phone or video. And of those folks, satisfaction was incredibly high. 82% of respondents of color said that they would likely choose a phone or video visit over an in-person visit in the future. So I think that, stats like this tell us that it's clear that telehealth and other patient-facing technologies are going to continue to be hugely important tools as folks seek to advance their healthcare goals. And we need to really continue to pay attention to issues of equity. Do people have access to the technology they need? Can they use it? Let's not let our technology have the unintended consequence of leaving people behind. I think with regards to community health workers, technology is really part of their toolbox, and increasingly so. They can assist people in accessing and using technology and in navigating those barriers, be it interacting with telehealth, patient portals, patient monitoring software. And I think they really have the potential to do more if they get the appropriate training to be able to do so. So I'm excited by the sort of untapped potential I see in this space, and hope that we start to see CHWs do even more in supporting members and interacting with technology in the context of managed care.
Yes, now, and I want to amplify Abner's thoughts that and his insights that, in terms of, one size does not fit all. And we really, we can't be overly dependent on technology. This is really a high touch and as well as high tech, but there's a high touch element that we have to make sure we don't lose sight of. But we do need the tech to give us the information and help us as a tool to target where do we need to focus our energies. In 2021, we launched a COVID vaccine confidence pilot to reduce vaccination gaps and address the disproportionate impact of COVID-19 on communities of color. And through that, we worked with community-based organizations, and we funded them as a trusted messenger to expand outreach to communities hardest hit by COVID-19. And using our partnership with Harmony Health, which is a digital outreach and engagement platform, which really enabled community-based organizations to increase their outreach capacity. That platform, the Harmony Health platform, allowed community partners to set up text campaigns that allow them to engage their members directly on their phones, as well as they were able to notify and announce events, as well as inform their clients where to find a vaccine clinic. The Southern California Pacific Islander COVID response team is one of the early adopters of this platform. They've been able to connect with the NHPI community members for various reasons, including conducting a needs assessment survey. We've also used other technologies to kind of pinpoint where do we need to focus our interventions. We developed a COVAX database and a dashboard where we were able to identify the areas of greatest unmet need through heat mapping. And we were able to align with the community-based organizations and faith-based organizations, such as the Cielo, Janet's organization, and Alici's organization, the PICRT, to concentrate our efforts in those specific zip codes and neighborhoods. Those dashboards, the COVAX and our health equity dashboards, have really been essential to our outreach and education efforts. The data, as I mentioned, allowed us to really pinpoint exactly where our outreach efforts needed to be focused and on which populations. I was happy but not surprised that our data was able to align with the state data on the communities of color and indigenous populations, which continue to be disproportionately impacted by COVID. So, it's a key partnership, that high touch, as well as, we need that technology to help identify where do we go, where are we lagging, which groups are lagging behind, and use interventions to address those.
I love that all three of you said that, tech is just a tool, essentially, right? It's the partnerships and all three of you also mentioned this, the partnerships with the actual community-based organizations and how important that is. And when we think about the urgency during the pandemic for people to get vaccinated, it became more critical. And Dr. Cruz, you certainly mentioned this, for Blue Shield of California to rely on community-based partners. And of course, we have two of our partners here today, Janet and Alici. Your organizations, we are so grateful for your partnerships. Can you describe how your organizations responded to the needs of our communities in regards to vaccination efforts and the pandemic?
One of our strengths, as I had mentioned, is that our community is really closely knit, and our relationships is really at the core of our cultural values. And so that was one of the biggest leveraging points for us, is our ability to come together. And as I said, our organization is a coalition of 20 different organizations that really reflects a Native Hawaiian proverb that translates to many hands make the work lighter. And so, coming together as a collective really allowed for us to leverage resources. If there was funding that came to one group that allowed for us to provide stipends or subgrants to some of the smaller groups, we were able to leverage funding. We were able to leverage strategies. Being able to utilize our different organizations to translate materials into our different languages was really crucial to our strategies. And also really one of the biggest things that we were able to do during the pandemic in partnerships with so many entities, including Blue Shields, is building our capacity. We really needed to build the capacity for our community. That meant we had to build groups of community health workers to be able to help navigate our communities to resources, navigate the systems that continue to be very confusing to many of our communities, and also be able to build vaccination clinics, testing clinics in partnership with our different counties, departments of public health. We were able to build those into our community. So rather than expect our community members who have language needs, who have transportation needs, to come out of their homes and travel far to large venues for testing and vaccinations, we were able to build vaccination clinics within our different churches in our different regions where we have communities. And so really being able to reach deeply into our networks and extend the way that our network reaches into the community to make sure that our most vulnerable are served. And then lastly, one of our biggest capacity that we were able to build here is communications. We know how important education has been in this pandemic because of the level of mis and disinformation that was spread and really impacted many of our communities who exist on social media and consume so much of that information there. We were able to build our communications capacity, and that also meant that our partnership with Blue Shield to be able to leverage the technology of Harmony Health gave us the capacity to be able to reach our communities through our text program that we were able to do with Blue Shield. We tapped into an existing program that we had. We call it the Wellness Phone Banking Program, which partners with not just our existing organizations, but with churches, with social groups, and provide them with stipends, train them on phone banking, and had them phone bank their own network. So rather than the traditional format where you cold call lists of people, we asked our communities to reach into their own families, their own congregations, their own networks, to check in with them to see how they're doing and be able to gauge what their needs are, funnel that to our community health workers and had them navigate them through resources. So we tapped into that model with Harmony Health, and we're able to utilize texting as a tool to reach our communities through some of our smaller organizations that had deep relationships. And so those are the ways that we were able to leverage this resource specifically to be able to use technology to innovate the ways that we're deepening our reach into our community. We hope that this isn't something that we are just doing now for the pandemic. We really hope to adopt it into our larger strategies to be able to address other health needs that our community is facing.
So just in terms of the work we do at Cielo, it's very similar to how she previously commented, that it's based on, the idea of the collective work for the collective good, which we say in Zapotec, Kuzuna. And so for us, it was really important to kind of operate in that way from our organization. It's one of our core foundational values that we're doing the collective work for the collective good of the community here in Los Angeles. For us in particular, we work maybe not only with Zapotec communities, but with Quiche communities, that our Indigenous solidarity, is beyond the nation state borders, because it's something that we saw that was a need. And in terms of the use of technology and knowing how it best serves communities, kind of like Abner mentioned, was really important, and not to leave anybody behind, like Carlene shared, right? But for us, the way that we were able to do this is we started developing a lot of materials in Indigenous languages. So I guess just to contextualize a little bit, because I know sometimes there's like a gap of knowledge on Indigenous languages. So it's really important to know who you serve, right? Like, let's say Zapotec, if you were to call for an interpreter in Zapotec, you would say, hey, I have a Zapotec speaker. I need a Zapotec speaker. You would say, hey, easy, Zapotec goes with Zapotec. It's a no-brainer. Actually, there's a lot of variants of Zapotec, right? There's 4 major regions where it's spoken, which is the Sierra Norte, the Sierra Sur, the valleys, and the Isthmus, which means that there are linguistic variants. This is very important when creating creating language access materials, because sometimes, like for example, in Los Angeles, we have a lot of Zapotecs from the Sierra Norte, specifically in the valleys. So if I was gonna make a campaign to outreach these communities, I wouldn't use an interpreter from the Isthmus, right? Because it just wouldn't land the same. Kind of like Abner said, you have to know who we have to customize, right? Who we're serving. We need to know the people that we serve. So I think that for us, then we started creating materials in Indigenous languages with audios, and we chose audios. I know that there's a big push for translation, for written materials, but what we've seen in our experience on the ground is that when we do push written materials for our community in particular, the writing Indigenous languages has not been systematized. It's very of recent times to write in the Greek alphabet Indigenous languages. It's a recent movement, and it's a movement that comes in spaces of higher education. And when you look at the numbers of Mexico, of the indigenous populations, you see that the numbers coming out there, the stats are that 1% have access to higher education. So this means that it's a very selective group of people that can read the written material in Zapotec or Mixtec. So we decided to do audios, right? Audio recordings that we then evolved to videos about the pandemic, about the different vaccinations, the boosters, the different messaging. We started having them in audios. In the audios, we decided, let's do animation. So we started doing culturally relevant animation for each of these videos. And if you look at the Cielo page, we have some one of the ones that I shared for everybody to get here that's participating is the one of Ayutla Mije, which is a language that is called Ayuk, but also Mije. And if you see the animation, it has, you know, the huipil, the traditional regalia that they would wear in that region with the, you know, specific Ayuk that's spoken in Ayutla, right? And we did this because, like we had previously said, we know in our data that there are a lot of Mijes that reside in Los Angeles that would understand that variant. So we customized that messaging on how to do a COVID vaccination test, and we were able to share it through social media. And social media has also proven to be a really powerful tool for us. There are a lot of people that are always plugged into Facebook. There are a lot of community groups, a lot of people, a lot of networks that are there. So we know that they get the message. And it's been funny because sometimes there have been messages recorded in Zapotec that the same person who recorded them gets them back, right? Like the communities are so tight knit that they'll send it to somebody that sends it to somebody that'll eventually come back to the person that recorded it in Zapotec. And so we love to see like how the work is being shared, how people are interacting with it. But it also is important to understand like the context that Indigenous communities face, especially when you're doing technologies that are supposed to bridge the gap for access, right? So I think it's a good reminder that a lot of these languages have been transmitted orally as opposed to text. So for us, it just works best to do audios.
I love that story. And I'll just add one quick example of work that I'm really proud of that we did when the pandemic first hit. As you know, people couldn't go into the clinics, and we had a lot of clients at Same Sky Health who were federally qualified health centers. These are the clinics where low-income people go for their help as part of the safety net. These clinics, some of them, their revenue went from whatever it was to 10% of that overnight. Now think about that. And some of these clinics were at risk of closing their doors permanently because they only got paid when patients came into the clinic. And that was a policy decision that was made before the pandemic that low-income people going to federally qualified health centers for care couldn't take advantage of virtual visits. Higher income people could use virtual care, this new innovation, but if you were low income, you couldn't take advantage of it, even though it had the potential to dramatically increase access because it, got rid of transportation challenges and other kinds of issues. So along comes a pandemic and policy changes and regulators, and I'm talking about California now, regulators in California said, okay, federally qualified health centers, you can get paid for seeing your patients virtually through but the patients had never done that before, ever, and neither had the clinics offered, virtual visits. And so we were able to help our clinic partners, our FQHC clinic partners, we generated about 50,000 telehealth visits in the first 4 or 5 months of the pandemic. And this goes to Carolina's point that these folks wanted virtual visits. They wanted to get care, and they were perfectly able to do it virtually. So I'm really proud of that work. A couple of the clinics said to us, you helped us from going bankrupt because we were able to see our patients. And even more important than that, you helped our patients to get care during this period when they couldn't get into the clinic. So I'm really proud of that. But let me just say this. This is an example of how we shouldn't do innovation. It shouldn't work this way, that it takes a 100-year pandemic to allow low-income people to get access to technology and innovation that the higher income people had access to all along and didn't even want to use. So I think this is a learning opportunity for us. And we should make sure that as we move, get past the pandemic, we don't go back to the old way of thinking and behaving. And we can get into that more, but it's a learning moment.
That is very well said, Abner. You know, to your point, we need to learn from all the work we've done during the pandemic, looking forward, moving forward. And so last question before we move on to audience Q&A, let's talk about that. Looking ahead, what are some key takeaways from your experiences during the pandemic that should be carried on? What are the essential elements for supporting our communities really to advance health equity? So Carolina, let's start with you this time.
Yeah, thank you so much, Shruti. I think, you know, there's so many incredible models that have been implemented. We've heard about a couple of them today with regards to community health workers and promotores working kind of deeply close to communities. So my hope is that we continue those programs and those innovations and we don't lose sight of them. I also think it's really important to recognize that some of the incredible policy changes and shifts that are happening right now that I think have really been propelled by what's happened in the pandemic. Specifically, I think it's important for folks to keep an eye on the new Medi-Cal state plan amendment that California is going to roll out this summer that would make community health workers a billable provider in Medi-Cal. A lot of community input has gone into that process. Additionally, there's a state budget proposal from the governor that includes $350 million for CHW training in support of increasing the pipeline of community health workers. So I encourage folks to keep an eye on that. And then, you know, engage with some of the resources we've generated about community health workers and promotores. Notably, I think it was chatted in earlier, we put together a resource guide for managed care entities who want to engage with this workforce. We spent about a year with 30 stakeholders, including community health workers, representatives from managed care plans, developing that resource guide, which is just an incredible synthesis of tools and information on how to implement these programs. So, you know, please honor that incredible work, take advantage of it. I know there's probably several folks listening today who participated in that process, and thank you.
I'll just add one comment. You know, we before the pandemic, a lot of our health plan partners were unable to communicate with their members, or really constrained in their ability to communicate with their members using text messaging, even though that's what members prefer. 10 to 1 when we ask them, they do not say US mail, send me a letter. They want to be communicated with through text messaging. That's the way America works in 2022. Before the pandemic, our plans were constrained. During the pandemic, because it was a public health emergency, the old, antiquated, outdated rules that prevent health plans from text messaging, using text messaging, those were waived, at least for COVID-related communications, which was wonderful. We actually kind of brought healthcare into 2022 because of the public health emergency. But now with the public health emergency about to end, again, this is an example. We should not go back to the old way. We should not go back to saying, okay, health plans, you can't communicate with your members in the way they prefer, and in many instances, the only way they're going to communicate. So we need to see these policies through a health equity lens.
Just, you know, to add to what's already been shared, something that we're walking away with is really building our confidence in centering our voices as community is key to creating strategies that work best for us. There's no equity without us. And I think, you know, that includes like some of our smaller populations, and, you know, including what Janet has shared. There's no health equity without equitable distribution of resources and investment in the communities that are most vulnerable. And so that means there's nothing about us without us. And so being able to center our communities and creating solutions is the best way to reach equity for our populations.
I think one of the pieces, at least for this component for me, is like the big takeaway can be by addressing the large language access gap that I'm sure is there, right? I know that we provide interpretations to the United States, and we've seen that there's very very little information about the linguistic diversity, right? Not just about Zapotec, but about Mixteco that has 81 different linguistic variants, right? So I think that in order to address the gap in health equity, we need to really also think about the way that systematic racism has erased Indigenous migrant communities, Indigenous communities, period, from the data, which really, really is a hindrance when accessing resources for Indigenous communities in California or in the United States, right? I think that that's one. Number two would be, we really, really need to invest in the training of interpreters. We have a program where we train Indigenous interpreters by professionalizing, but also with all the jargon and all the terms and the vocabulary, right? Because we didn't get to talk a lot about this, but there is a gap when we see the professionalization of interpreters, right? We need to continuously train them and give them access because they're one of the first people in line when they're providing interpretation when accessing care in the healthcare system, right? When they're going to hospital visits, when they're going just to access basic needs like a health wellness checkup. Like if your interpreter is not trained and does not have the professionalization, the interpretation can do more harm than good. And also it's important to really address the lack of knowledge of service providers, because sometimes they're like a Zapotec with a Zapotec, good enough. We don't have to see if they actually understand each other. And we've seen cases in which this has happened where there have been, they have not been linguistic matches, yet they still move forward and interpret for them. So it's also very dangerous to not know the communities you serve. And this kind of information where it's really important to know, like, hey, there's linguistic variations for different languages. And it's important to know as healthcare providers that, hey, we need to make sure that we're providing an interpreter, one, that's trained, and two, that actually has the same variant as the patient that I have in my office, right? So I think that these are some of the takeaways for me.
Thank you, Janet. Dr. Cruz, last but not least.
Oh, well, thank you. I think one of the, the title of this session is Innovations and Collaborations to Support Community Health. And I think one of the innovations is just that, collaboration. We've really seen how important it is. And we've learned this lesson that the importance of proactively developing and maintaining, these ongoing and strong relationships with community-based organizations, that we as a health plan, in part of developing our own internal workflows and systems, we have to ensure that it incorporates our community partners so that we can effectively address health and social needs of our members. When we utilize technology, one, I think it's been emphasized, and I want to just amplify that, it's a tool. It's not the solution, but it's a tool. And we need these tools to be able to reach our members. The importance of the heat mapping, and as Abner and others have mentioned, the importance of using text campaigns to be able to reach out. And I think one of the other important things that we have to be mindful of is that some of our members in these communities, they reside in digital deserts. That the internet companies, they may not have laid the infrastructure that really allows for reception. So we have to be thoughtful of how do we go about communicating with individuals when they're in those kind of environments, or the economics of being able to sustain their connectivity is a challenge. How do we ensure that? Those are two ongoing things. So again, the tech is a tool, but we have to make sure that we don't use it. It's not the only tool that we use to communicate and reach out to our members.
That's great. Well said, Dr. Cruz. So we only have a few minutes left. It's too much to talk about. We didn't get to a lot of questions, but I did want to do at least one audience question. How can we show the value of free low-cost services to encourage immigrant and marginalized communities to engage with service providers? I think our community folks here might have some great feedback on this one. And what do stakeholders need to do to garner the trust of these communities? So if we could do a rapid fire for folks.
Really quickly, hire line staff that are from the communities. In most cases, some of those line staff speak the language, understand the culture. And because trust is at the core of being able to reach community, having line staff from those communities is something that will help build trust. And if that's something that's difficult, I think what we're showing here is partner and collaborate with community groups that are actually from those communities.
Love that. Exactly. Amazing.
I just want to add, some of the things to help support the development of these community health advocates, and Alicia said is sometimes the very members that you're serving are wonderful, have wonderful potential, and are interested and eager to become a health advocate. And so to pick up on that and recognize that it's not only providing services to individuals, but you may be helping develop the very next community health advocate.
To our panelists, thank you so much for taking the time. You're doing incredible, impactful work, and we just really appreciate your engagement and you all being here today with us. Thank you.
Thanks very much.
Thank you all.